Again, I'm Dr. Amelia Wiggins. I'm an orthopedic surgeon with OrthoCincy, and today I'll be giving a presentation, a little webinar on if a total knee replacement or a partial knee replacement is right for you. All right, this is done in partnership with Christ Hospital, with the Christ Hospital, like the Ohio State, they like to say. That is where I do some of my total knee replacements at the Christ Hospital downtown. I also operate out of their surgery center on Red Bank. You can read a little bit about Christ Hospital here. They recently built their joint and spine center, and it is state-of-the-art, absolutely magnificent, beautiful operating rooms. They have the MAKO robotics for joint replacements. We'll talk a little bit about that today. Just a wonderful facility. Okay, so a little housekeeping. You are all muted. I cannot hear you. I cannot see you. I wish I could, but please type your questions, comments, technical difficulties in the chat box, and then we can respond to those live. I have my husband actually doing technical support for us here, so he'll take good care of you. And then at the end, I'll go through and answer all of your questions, okay? This is also being recorded, so if you miss a little bit or you want to circle back to it later or share it with a friend, please share with a friend. You will receive the email link to the recording within the next couple days. All right, let's get going. I have no disclosures. So today we're just going to talk about you. We're going to talk about your goals, your limitations. We're going to go through your anatomy so you can better understand what's going on in your knee when it's healthy and then transitioning to an arthritic knee. We're going to talk about what your treatment options are because those are different for everyone. And then we'll talk about your plan. What can we do for you? At the end, of course, we'll do questions and answers. But first, a little bit about me. I am a wife, as I mentioned. My husband is here doing technical support. I am a mom. I have two boys, age 7 and 2.5, and they are, as you would imagine, a 7 and 2.5-year-old boy are. They are hilarious and they keep me on my toes. I'm a surgeon. I'm an orthopedic surgeon, which I absolutely love my job. I do a lot of knee replacements, hip replacements, and I do a lot of arthroscopy or scopes as well on young athletes. I am an athlete. I was a soccer player and a rower. I still am active hiking. I just hiked the Grand Canyon last year, which was amazing. So try to stay very active. And I'm also a patient, so I kind of get this. I've had a handful of ACL surgeries, unfortunately, throughout my time as a soccer player. So I know what it is to be on the other side of that table and to be talking to your doctor. I know it can be a scary place. So these talks are important to me. So first we'll talk about, this is one of my actual patients, Kathy. She was gracious enough to let me speak about her. She is a 71-year-old woman. She enjoys walking 2 to 3 miles with her husband. She loves playing with her grandkids. And when she came to see me, her main complaint was that over the last 6 months to a year, she was having to limit her evening walks due to pain. She was having to sit out at family functions instead of playing with her grandkids. She was declining things because of her knee pain, and it was really bothering her. So she wanted to talk about what we could do. And if that sounds like you, then you're in the right place. So when you go talk to me or another orthopedic surgeon about your knee pain, one of the main things is getting your goals across. Kathy's goals were to walk 3 miles a day, have less pain. She wanted to chase her grandkids. She wanted to maximize her social opportunities. So as we formulate a plan for her, I need to know all of those things so we can make the right plan. So as you come, what would your ideal look like? Is that walking in the park? Do you want to get back to hiking and biking? Is it chasing the grandbabies? Do you want to run a marathon? Because that would definitely change our treatment options. What do you do for a living? All of those things matter as we're talking about what to do for you. So a little on limitations. Kathy's knee pain was keeping her from the life she enjoyed. People ask me every day, when do I know it's time for me to get my knee replaced? And I say, you'll tell me. It's not something that I can tell you. I don't just treat an X-ray. I don't just treat pain. You treat a combination. And when your knee pain is limiting you from the things that you want to do, then maybe it's time to consider next steps. Are you worrying about how your knee will feel a day or two later after you walk in the park? You know, does it keep you up at night? Are you using a cane or a walker now because of your knee pain? And then another thing to consider is what else is limiting you? You know, maybe there are some other medical problems that are limiting you. Maybe you're having shortness of breath from a heart or a lung issue, and it's not just the knee. You know, if I put a brand new knee in you, but you still can't walk because you have, you know, some other medical condition, then we might not have done such a great service. So let's talk a little bit about the anatomy. The knee is a hinged joint. It has the femur, the tibia, and the patella. So the thigh bone, shin bone, and the kneecap. And those come together and rotate as a hinge. The ligaments stabilize the knee. You hear a lot in our athletes about athletes tearing their ACLs. That's the ligament in the front of the knee. It keeps you stable from when you pivot and go side to side. You have the lateral and the medial collateral ligaments that protect you on either side. Between the bones, you have the meniscus and the cartilage. The meniscus, I think of as the brake pad to the knee. That's the shock absorber. And as you get arthritis, that meniscus starts to break down. The cartilage is the other shock absorber to the knee, and that's that white area you see on the bone there. As we get arthritis, that starts to wear down, and the bones get closer and closer together. There's joint fluid in the knee. This is typically lubricating and helps us. As we get arthritis, that joint fluid decreases, which is why you have more stiffness, dull, achy pain, some grinding and cracking. Just a fun fact, women lose the cartilage, they lose that protective barrier faster than men. So knee arthritis, especially under the kneecap, is a little bit more common in women, actually, just from the way our skeletons are built. So here is kind of a side-by-side of what a healthy knee looks like, with a lot of space between the bones. The articular cartilage, the white area, is nice and smooth and shiny like a pool ball. We have a lot of joint space. The meniscus is intact. As we get arthritis, the cartilage is lost. You can see that now we have exposed bone underneath there. The meniscus starts to wear out, just like your brake pad would. It starts to wear out. The bones get closer and closer together. When that happens, then the body tries to help and puts on extra bone. And that's what we call a bone spur or an osteophyte. And this is these extra areas of bone that the body is putting on that are not necessary and certainly cause problems. So as you come to the office, the first thing to do is to get an X-ray to see really what's going on. You can see on the far side, they can see my mouse, right? Okay, on the far side, you can see my mouse pointing to the healthy knee X-ray with joint space between the bones. As we go to the next picture, we see that the joint space is still there. You know, we still have a little joint space, but now we have an osteophyte. This is that extra bone that I'm talking about that we start to see with early arthritis. So we have an osteophyte, so I can look at that X-ray and say, you know what, things are changing in your knee. You've started on this arthritic cascade. But at this point, you don't need a knee replacement. This is when we talk a lot about non-surgical options. With time, of course, you know, everything gets worse, just like the tread on your tires, things wear down. Now we see in the next page that the joint space is starting to narrow. We have less space there. That means that meniscus is getting pushed out. The cartilage is starting to wear out. This, you know, is worsening arthritis. The next phase is where you finally have bone on bone arthritis. And that's these last two pictures. The very last picture being the more severe arthritis with a prominent, you know, a lot of osteophytes, a lot of those bone spurs are occurring there. When it starts to get bone on bone, that's when people have a lot of pain, a lot of stiffness. They lose motion. You know, they start to notice some tightness even in the other muscles. They might not be able to straighten or fully bend their knee anymore. So back to our patient, Kathy, she came in to see me, and these were her X-rays. So she has bone on bone arthritis here and here on the inside of one knee and the outside of the other. We talk about the medial and lateral compartments. So she has bone on bone arthritis, and she started to ask me, you know, what can we do? What should we do about this? So treatment options. The main question is, what do you want to do about your knee pain? Maybe all you want to do are injections or therapy or medications, and that's great. You know, maybe you've tried all of that and you're ready to talk surgery, but understanding really what you want is very important. And then the next question is, what are you able to do about your knee pain? How old are you? You know, if you're in your 20s and you have a lot of knee pain, a knee replacement is probably not for you. If you're 90 and you have a lot of knee pain, maybe a knee replacement still isn't right for you. It really just depends. Maybe you're just right. What allergies do you have? This is one that a lot of people don't think about, but the implants we put in have metal in them, you know, and so if you have a metal or a nickel allergy, we do need to know about that because it will change our surgical plans. What medical history do you have? There are a lot of reasons why you can and cannot get a knee replacement, you know, but if you've had a recent heart attack or a stroke, things like this, if you're on blood thinners, there are certain things that we need to manage, you know, that we need to make sure are optimized before we start doing a knee replacement. Social considerations are needed. You know, maybe you have a huge fear of needles and injections are never going to happen. Well, great, we will take that treatment option off the table immediately. Maybe you don't have transportation or a big family support, you know, and so then we'll need to adjust our treatment plans before, during, and after surgery. Weight and smoking are two big things that will limit your ability to get a knee replacement. The BMI, your height-weight ratio, we really need that to be less than 40 for your safety. You know, if your height-weight ratio is more than 40, you're going to wear that knee out faster and you're at a much higher risk for complications. So we try to, you know, get you to lose weight. We keep your pain under control with injections. We do need that weight to be down in order to safely proceed with a knee replacement. And smoking is the same thing. Smoking it decreases your healing. So we need you to stop smoking. So what can we do? What are some treatment options? Well, most people, by the time they come and see me, they've tried a few things. They've tried some ice, they've tried heat, they've tried ibuprofen, things like that, Tylenol, and those are all wonderful things. People usually have a brace that they've tried. There's a number of things. There's a number of supplements like glucosamine and chondroitin. The topical arthritis creams like Voltaren now are over the counter instead of prescription, and I love those. I absolutely think that they are so helpful for arthritis. Physical therapy is a huge treatment option for arthritis. The more motion and strength you have in your leg, the less your arthritis will bother you and the better you will be if we decide to move forward with surgery. The stronger you are, the more motion you have before surgery, the better your outcomes will be afterwards. So those are the more conservative treatment options. More invasive treatment options include injections. There's three main types of injections. The first is a cortisone injection. That's a steroid that can be easily done in the office. We put this steroid in, it calms down the arthritis. You know, arthritis, I think of it as a bit of a roller coaster. Some days, some seasons, you're okay, you can get on fine, and then something happens. You twist, you turn, you melt down, you irritated that knee arthritis. We just need to get it back the way it was before you aggravated it. And that's where a cortisone injection can really come in handy. And those last anywhere from 6 to 12 weeks, typically. The viscosupplementation injections, I call them the gel injections, or people say it's the rooster comb injections. There's some commercials on TV advertising them as a cushion to help give back the cushion that you lose with arthritis. Those injections are so helpful. I use them on a daily basis in my practice. It's a 3-shot series. Typically, you get 1 injection a week for 3 weeks, and it helps to build back that normal lubrication fluid that we lose when we get arthritis. Another type of injection are the biologics, and these are really gaining a lot of traction, and for good reason. They're so helpful. The PRP injection is a biologic. So it's a platelet-rich plasma. I take the blood from you in the office. It's an in-office procedure, and I spin it down, get the healthiest cells out of it, and then I inject it back into your knee. It causes a positive immune response. So it helps to regenerate your own tissue. So helpful. Insurance does not pay for that at all. But we can certainly talk more about if you're a candidate for that. And the person that is a candidate for that is when you're in that moderate arthritis. It's, once it's bone on bone, that's probably too far. But if you're in the mild to moderate arthritis, you still have space left on your x-rays, PRP injections are phenomenal. One of the big things that everyone can do to help with their knee pain is lose a little bit of weight. For every 1 pound you lose, that actually takes 4 pounds of pressure off of your knees. So I know people come in and say, oh gosh, yeah, I have to lose 50 pounds. No, we don't need to get overwhelmed with 50 pounds. Just lose 5. Just lose 5. Your knees will feel better. You will feel better. Tackle it small little bits at a time. All right, so that's all of the conservative options. Now let's talk a little bit about if we do need a surgery. A lot of people come in and ask if they need a knee scope, an arthroscopy just to trim out that meniscus tear. Sometimes that's indicated. A lot of times it's not once you have a lot of arthritis. So we can kind of put that aside for now. The other two main options, which is why we're really here today, is the partial knee replacement and the total knee replacement. So the partial knee replacement here is where we just replace one compartment of the knee. The total knee replacement is the entire knee gets replaced. And we'll look at what these partial knee replacements look like. So you can see the white is obviously the healthy, and then the red is the unhealthy portion of the knee. So if you have arthritis just in one part of the knee, in the medial compartment, the lateral compartment, under the kneecap, which we call the patellofemoral compartment, or sometimes occasionally in 2 compartments. If you have arthritis that's just localized in one spot, then the partial knee replacement is a good option for you, or could be a good option for you. Here's what the different x-rays look like. So this partial knee replacement, you can see the metal is just in the medial compartment, this inside compartment of the knee. This outside compartment looked healthy on x-ray, so we didn't need to replace it. And then this is what the total knee replacement, the x-ray looks like, where the metal, now this implant goes, on the femur and the shin bone, on the tibia, and then a plastic piece in the middle. So that's the 2 differences there between the partial and the total knee replacement. Okay, so if you've come to my office, we've talked about your arthritis, you are, a surgical candidate, surgery is what's right for you. What do we do next? Well, we develop your plan. So we've already considered your goals. We've talked about your x-rays. We've gone through your physical exam. We're going to make a plan now that's right for you. Prior to surgery, we have you meet with your primary care doctor, get your lab work, make sure that you are healthy enough for surgery, of course. And then we will do a CT scan to help me with the surgical part of the surgery. And we'll also have you meet with our physical therapist. We get a little baseline work, see what your range of motion and strength are before surgery. That way we know you've met your goals at the end, and they'll start teaching you some exercises that you can do before surgery to help with that recovery. So my favorite part, of course, is the knee replacement. And this is so cool. We have such great technology now, but this is the MAKO robot that I use during surgery to help make that total knee replacement as patient-specific, as accurate as it can be. This technology is amazing. And we'll go through a video in a few minutes showing this a little bit. But what we do is we get a CT scan of your leg beforehand. That creates a 3D model in the computer of your knee. I can play with that model before surgery and decide how much bone I want to take off. When we did knee replacements before the robotic technology came about, it was kind of one size fits all. You take off 1 centimeter of bone on every compartment, you put the knee replacement in, and then we would adjust, we would balance the knee based on releasing the ligament. So I would do a lot more with the soft tissues, those ligaments we looked at. I would release one, I would make one tighter, make one looser, things like that. Now I can do all of that with the bone, and I leave the ligaments alone. which makes your recovery faster. And it fine tunes what I take. So now I can take 4 millimeters of bone from here and 1.5 millimeters of bone from here, because that's what you need, not a one size fits all approach. So now we'll watch this video. It just talks about the MAKO, the technology, and how I use it a little bit in surgery.
Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of X-rays taken at different angles that can help surgeons see things that they can't typically see with an X-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the MAKO system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the MAKO system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
Okay, perfect, good. So I hope that was a helpful video. I think it's so fascinating, the technology. So I do the surgery before I even do the surgery, which is, I absolutely love it. And with this, like I mentioned, we don't have to do as many soft tissue releases. So that makes it less invasive. The incision is still the same size. We'll make that very clear. Incision is still the same size, but it's less invasive because I'm doing more manipulation on the bone and not the ligaments. So therefore, patients have lower pain scores afterwards. They have quicker recoveries. Patients are going home the same day and getting back to what they want to be doing so much faster than previously. And then the other thing I just saw on here, the preservation of healthy bone. The other huge part of this is, like I said, I can take 4 millimeters of bone instead of that centimeter or whatever those numbers are for you. And that means if we do need to come back later, if you do wear this knee replacement out and we need to come back and do a second surgery later, that means I have more bone to work with that second time around, which is incredible. So what would this look like? What would the day of surgery look like? Well, you would arrive at a surgery center or hospital, oftentimes at Christ Hospital where I do these. You'll arrive very early, very, very early. You'll get there, they'll start your IV, get you ready. The nurses will talk to you, ask you a bunch of questions. We'll talk with the anesthesia doctors. We do a general anesthetic, which means you do go all the way asleep. We can do a spinal, that's patient specific. Before surgery, you get a nerve block, and I do a special nerve block that helps with pain, but leaves your function, okay? So you don't have as much weakness afterwards, so we can get you up and walking the same day of surgery, just within a few hours of surgery, actually. And then during surgery, I put pain medication throughout the knee, in the front, the sides, and the back, and that time releases over about 3 days, so that limits the pain you have afterwards. Physical therapy, we start outpatient therapy 3 to 5 days later. So if we do this on a Friday, you're in therapy Monday or Tuesday, and you're going. We discharge you home often the same day as surgery, unless you have some medical, comorbidities that need you to stay overnight in the hospital. 90% of my patients are going home the same day and recovering at home, which is really the best place to recover. So there you go. Understanding your recovery, home the same day. Outpatient therapy starts anywhere from 3 to 5 days after surgery up to 2 weeks. By 4 to 6 weeks, patients are driving, they're returning to work, they're back to their activities of daily living. By 6 weeks, I need you to have your full range of motion at that point. That's really the main goal. So by 6 weeks, you should have your full motion and working towards full strength. By 6 to 12 weeks, my patients are back golfing, biking, walking, hiking, doing their recreational activities. If you are a laborer, I have a number of patients that, are laborers. They're back to work doing their physical jobs, typically at 12 weeks. And I say all of that, but it does take a full year. It absolutely takes a full year to recover from a knee replacement. Your body will continue to change. It will continue to heal. You'll continue to get used to this new knee. And it really does take a year for that. So, realizing your goals. With the help of the MAKO, Kathy did go home the same day. She started physical therapy the next day and then transitioned to outpatient therapy. She had a very strong family support, which is so helpful when you're going through a major surgery like this. And then at 1 month, I saw her back. She was back playing with her grandkids. She was already working up to walking 1 to 2 miles at a time and was loving it. At her first visit, she went ahead and made plans to have the other side replaced. And these are her initial x-rays. All right, that's it. We've made it. So I'll leave this screen up and you can see how to schedule with me. Those are our office locations. At our Eastgate office, we do take walk-ins Monday through Friday from 9 to 5, and then actually on Saturday from 9 to 1. So if you ever need anything, or if you have a grandkid that gets an ankle sprain or a knee injury at soccer practice or a broken bone, we're always here. So I'll switch over to Q&A and read these questions. All right, so this first one, 53-year-old male, are there any activity limitations I should expect after a full recovery? Hopefully not. You should be able to get back to everything you want to do. I say that with a disclosure of any high impact activity like running, doing marathons. We don't recommend that you run on a total knee replacement because of the high impact. You will wear out that interface where the joint, where the metal meets the bone. The sooner you wear out a knee replacement, the sooner you have to get a second one. So we tell you to avoid high impact activities. But after that, other than that, you should be able to do anything. How long should I expect a knee replacement to last? 20 to 30 years. So a very, very long time. A partial knee replacement is about 10 to 15. So those we tend to do in our younger patients, that we know we're going to have to come back later and do a full replacement. We do the partial first. And then the full knee replacements are getting 20 to 30 years. The question, is there a minimum age required before a knee replacement is considered? Oh, yes and no. It depends. Every patient's story is going to be different. It depends on, it depends because you're going to wear the knee out. If I replace the knee of a 25-year-old, we are absolutely going to expect to have to replace that again, maybe even twice in their lifetime. So we want to be mindful of that. So we want to wait as long as possible. I always say, keep your own parts, as long as they're working for you, keep them. But a minimum age, yes and no. That's very patient specific. What does the prehab look like? It is wonderful. I now make it a requirement for all of my patients because I think it helps you have the best success you can have. So what they do is they go through range of motion. They go through what your strength is. They have you walk and practice getting up and getting down. They're going through all of these tests. And then they give you some exercises to start doing. So you start working on your strength and your range of motion. And what that does is it helps you, have a faster recovery because you're that much stronger beforehand. But basically the prehab, we just want to get a baseline of where you are. So we get you back to your baseline and hopefully better after surgery. It's a quick visit with the therapist, and it's just one time before therapy, before the surgery. Let's see. What are the steps and stages before a knee replacement is considered? And that also depends. Some patients come in, if you think of that slide where we had all of the x-rays lined up, if somebody comes in with very early arthritis and says, oh, my knee really hurts, well, you don't have bone-on-bone arthritis yet. I'm going to talk to you more about therapy, activity modification, bracing, maybe some injections, and try to let you live with that knee as long as I can. If somebody comes in at that first visit and has that x-ray that was just bone-on-bone and terrible, terrible arthritis, well, there's no point in trying injections unless you really feel strongly to do that. If you want to do a knee replacement, your x-rays are indicated, your physical exam is indicated, we will absolutely skip all of the other steps and go straight to a knee replacement. Next question is, what is the typical time frame for recovery? Like we talked about, the first 6 weeks are really critical in getting that range of motion and strength back. That's when I think it's most important to be working with your therapist. My patients work with their therapist anywhere from 6 weeks to 12 weeks typically. And at the 12-week point, it's really patient-led. If they haven't met a goal, then they'll keep working with the therapist. So 6 to 12 weeks of therapy, but then it really is a full year recovery from a knee replacement. All right, next question is, what is the cost and is it covered by insurance? The cost of a knee replacement varies based on location, what we use, anywhere from $20,000 to $30,000, to be honest with you. But yes, they are usually covered by insurance unless you are self-pay, But yes, most insurance companies cover this, and I don't think patients pay too much. Yeah. Are there any risks? Yes, there are risks, of course. Anytime that we do surgery, there is always a risk of nerve damage, blood vessel damage. There's infection is always a risk. Stiffness afterwards and instability of the knee. There's, of course, multiple things that can happen. We do everything that we can to avoid those things. We try to optimize you as best you can. So if you are a little overweight and you're a diabetic and a smoker, those are 3 things that will really increase your risk for infection. So we're going to try to get you to stop smoking. We're going to try to lose a little weight. We'll make sure your diabetes is well under control so we can minimize your specific risks as best we can. Somebody else asked, they had one of these gel injections a couple of weeks ago. It's not working. Should I consider surgery? Maybe. I can't say for sure because I haven't seen your x-rays and I haven't talked to you. But if you want to schedule an appointment and come and talk to me, I can look at the x-rays. We can go through it all and talk about what the next step is. Is that all of them, or should I scroll? Oh, I got to scroll. Okay. Yes, the famous question. Everyone always asks this. Can you do both knees at once? No. Yes, technically you can, and people do. But the literature will show that there's a higher risk of complication during and after that surgery. So in my practice, the answer is no. We are not doing 2 knees at once. We'll do 1. We're going to make sure you love it, have a good result, and then we'll come back when you're ready and we'll do the other side. I just don't think it's worth the risk. Like I said, I like to maintain, and minimize the risks as best I can. So it's just not worth it. Great question. Do you offer a joint class to learn more about the knee replacement prior to having surgery? Yes, 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 yes. This is huge. The more you know about your surgery, the better you will do. Health literacy is what we call that. The more you understand about what I'm going to do, about what you are going to do in physical therapy, the better you're going to do. So what I do is I make it a point to bring you back to the office 2 weeks before your surgery, and you meet with my team and we go through everything, what to expect, and you bring your loved one with you. So we don't have a class where 20 people are gathered together. This is a one-on-one appointment in my office. You bring your primary support person that will be with you after surgery, and we go through what to expect, what to bring the day of surgery. We give you your walker, your brace. We send your medications beforehand. We go through the whole class before surgery, so you have a good idea and your family member has a good idea of what to expect. So important. I think that's it. All right. Perfect. Yes. Okay. I was just reading the final things just to make sure I didn't miss anyone's questions. Yes. Thank you guys so much for coming. I hope this was helpful. It's really fun for me to do, and I hope I get to meet some of you guys over the next upcoming weeks. You know, if you have more questions, if you want to talk to me one-on-one, just make an appointment. We'll go through it all again. I can't wait to meet you. Thank you.